Hello my dear students, I'm Dr. Vaishali Bharambe. I've been teaching anatomy for more than 25 years and I love it. Today we are going to talk about the development of male reproductive system. Last time in my earlier lecture, I've developed the testes, but it's right there in the dorsal abdominal wall. How does it come from there into the floor of the scrotum? What are the factors that bring about descent? At the same time, what are the anomalies in the development of male reproductive system? All this and more in today's lecture. Come. So first let's talk about that testis which is stuck in the dorsal abdominal wall. Question is, why the descent? I'm sure all of you know why the descent. Testes cannot survive in the high abdominal cavity temperatures. So that means they have to descend. From where to where do they descend? From the dorsal abdominal wall to the scrotal sac. That's the extent of descent of testes. So, what is the situation like now? The testes have been developed. They are right there in the dorsal abdominal wall, quite close to the diaphragm, suspended from the diaphragm by the suspensory ligament at the cranial end. Think of them as a pendulum. Nowadays, you don't have watches which have wall watches which have pendulum in them, in case you have seen one. Imagine that testis is suspended from the diaphragm, by a suspensory ligament. At its caudal end of the testis, it is attached by the inguinal fold to the genital swellings. So, anchored above by suspensory ligament, anchored below by inguinal fold. Now what happens? Within the inguinal fold, a fibromuscular band develops. This fibromuscular band is called as the gubernaculum. Now what happens? The testis is here. This is the peritoneum that is covering the testes. This is the gubernaculum attaching the testes to the early scrotal sac. Early scrotal, there is no scrotum developed yet. Now, a projection of peritoneum comes to cover over the testes, forming a little sac, which is called as the saccus vaginalis. Okay, up till here? What do we have here? What do we have to create the descent of testes? Come. We've got a developing testis in the dorsal wall. It is suspended from the diaphragm by suspensory ligament. It is covered by a little sac called saccus vaginalis. It is attached with the help of gubernaculum to the scrotal sac. This is what we've got. From all this, we are going to create a descent of testes. Come. So now, before we allow the testes to descend, what is this gubernaculum? This is a fibromuscular band which is attached at the upper end to the testes, to the mesonephric duct, to the overlying saccus vaginalis. As it travels downwards through the inguinal fold, it gets attached to a lot of lower areas by splitting into tails, which are called tails of Lockwood. Where does it get attached? Gets, of course, attached to the bottom of the scrotum. It can get attached to the superficial perineal pouch. It can get attached to the base of the penis, to the saphenous opening, to the anterior superior iliac spine. Basically, gubernaculum comes down and splits like that. Now, steps in the descent. Testis is there. What happens? What happens is, firstly, the suspending ligament disappears. The suspensory ligament, which was attaching the testis to the overlying diaphragm, disappears. Testis has nobody holding it up, right? So what happens? It begins to descend down. As it descends down, the gubernaculum also shortens it. It's like, I don't know how many of you have had kite flying competitions, but you remember there is a thread and there is a kite. So as you pull on the thread, the kite can come down. The same thing gubernaculum is doing. It's pulling on the testes, causing it to descend downwards. As it descends, a pouch of peritoneum passes, traveling in front of it, leading the way. This is your saccus vaginalis. With time, what will happen? The gubernaculum will shorten to form the scrotal ligament. The testes will descend down and come to lie inside the scrotum, anchored down by the scrotal ligament. The processus the saccus will increase in length to form the processus vaginalis, which at one point will disappear, leaving a little sac surrounding the testes called as the tunica vaginalis. Take a look at it again. The processus vaginalis will obliterate, leaving behind a little sac that surrounds the testes anteriorly, and this sac is called as the tunica vaginalis. Okay, so now you have the testes here. This is just a revision. Anteriorly, the processus vaginalis is leading the way. Once the testes reach the floor of the scrotum, processus vaginalis gets obliterated, leaving behind a little sac which covers the testis incompletely, called as the tunica vaginalis. This sac has got an inner layer called as the visceral layer and an outer layer called as the parietal layer with a little bit of space in between. Okay, that's the tunica vaginalis sac which is covering the testes. Question is, are these the only coverings for this precious gonad? No. As the testis descends, it also acquires more coverings. Come take a look. So this is the descended testes. As it passes through fascia transversalis, it acquires an internal spermatic fascia. As it passes through the internal oblique muscle, it acquires the cremasteric fascia. As it passes through the external oblique, it acquires the external spermatic fascia. So the testis is not only covered by tunica vaginalis, it's covered by 3 more coverings, which are acquired as it was descending through the inguinal canal. Clear? Just a quick recap. Fascia transversalis, internal spermatic fascia. Internal oblique, cremasteric fascia. External oblique, external spermatic fascia. What about transversus abdominis? Nothing, because testes never pass through the transversus abdominis muscle. Right. So with this knowledge, we have descended the testes into the scrotum. We've got its layers covering it, tunica vaginalis, the various fascia covering testes. But what were the steps in the descent? At 4th month, the timeline is testes was in iliac fossa. At 7th month, it was at the deep inguinal ring. At 8th month, it was traversing the inguinal canal. At the end of 8th month, it was at the superficial inguinal ring. In the 9th month, it entered into the scrotum. If it doesn't, then by the end of 6 months to 1 year, it manages to descend down. This is the timeline, you must know it. Now, question is, what are the factors in the body that cause the testes to leave the abdominal security and come and lie in the scrotum? One is the shortening of gubernaculum. Remember, I'm giving you a mnemonic, pay attention. Shortening of gubernaculum, release of testosterone from the interstitial cells of Leydig, raised intra-abdominal pressure, raised intra-abdominal temperature, both. Straightening of the fetal curvature along with contraction of the inguinal canal muscles. You remember it passed through all these muscles? These literally squeeze the testes into the scrotum. So what's your mnemonic for this? Capt GT. I don't know if it works for you. It worked for me. So how do you use it? Okay. The C is the fetal curvature. A is the arched fibers of inguinal canal. P and T are the pressure and temperature of abdominal cavity. G and T are gubernaculum and testosterone respectively. Use a mnemonic or create one for yourself. Do not forget the factors that cause the descent of testes. Okay, so why the descent? Why the descent? Why should the testes like ovary not stay inside the abdominal cavity? So, the scrotal temperature is 2 to 3 degrees lesser than that in the abdominal cavity, and this is a temperature which facilitates normal sperm maturation. Descended testes provide necessary conditions for the Leydig cells to develop so that they can secrete adequate amount of testosterone. Undescended testes are prone to cancer. They are all less, it is said that testes lying in the scrotal cavity are less prone to injury. I have my own opinions on this, but so it is said. Right. So these are all the factors that are the requirement why the testes need to descend. Right. So development of testes is a very complex and highly coordinated process. And something definitely goes wrong in many cases. So what are the things that can go wrong? What can go wrong? One is you find the child is born, male child, and there is no testes in the scrotum. That's the first thing that can go wrong. Now, what do you do? What are these conditions in which the child is born without a testes in the scrotum? It can be one anorchism. Testes is not formed at all in the child. That's a very rare condition, but you have to consider it. How do you differentiate that from cryptorchidism? Think, find out. Answers given in the notes if you can't find out. Monarchism. One testis has descended, other has not developed at all. That's also a possibility. And the third condition is called cryptorchidism, when the testis has not descended. It's formed, but it's not descended. A case of undescended testes. Right. So this is seen in about 3% of the all male born babies, which at the end of 1 year usually find the testes manage to find their way into the scrotum. But if the testes are not there in the scrotum, where are they? Where are they? So they can be completely undescended, in which case they can be in the abdominal cavity. They can be partially descended. So they can be at the deep inguinal ring, in the inguinal canal, at the superficial inguinal ring. Just above the normal position of the testes is also considered as a partially descended testes. So you can find them anywhere along the normal path of descent. Clear? Okay. So what are the causes of non-descent? What really happens? Why don't they descend? There can be factors like hormone. Okay, if there is less testosterone, testes are not going to descend. Mechanical factors like maybe the inguinal canal is not developed. Maybe there are facial adhesions in between. Testes can't push through all this. Or you can have genetic abnormalities. A person has Klinefelter syndrome. Person has Prader-Willi syndrome. These are clearly conditions where testes are not going to descend. Maternal factors like the mother delivers in the 6th month, 7th month. There's no testes have not descended by then. You know the timeline by now. So that's a very common cause. Neurological factors such as impaired development of genitofemoral nerve. That's a nerve that stimulates the gubernaculum to pull the testes down. And idiopathic. All these are causes of non-descent. Please learn them well. They're asked very often. So how are you going to treat this person? One is wait for simultaneous descent. Wait. Allow it to descend. 2. Give hormone. Say human chorionic gonadotrophin is given. It stimulates descent. 3. Perform orchiopexy. Find out where is the testes. In the 6th month to 1 year of the child's life, you find the testes, you bring it into the scrotum and you anchor it. Of course, it's not that easy. Remember, testes has a vast difference attached to it. If the vast difference is short, how are you going to move it into the scrotum? These are difficult surgeries, but they must be done because otherwise there are complications. And of course, you have to keep regular follow-up to make sure that this child does not go into infertility in his adult life or does not develop testicular cancer. With this, we come to why the follow-up. Why the follow-up? Because this condition results in complications. If you have not re-anchored the testes at the right time into the scrotum, the adult is going to be infertile because the testes no longer have ability to produce active motile sperms. Second, this testis has been exposed to such temperatures that it is very likely to enter into testicular cancer. The malpositioned testes have more chances of undergoing testicular torsion and associated inguinal hernia because it's associated with non-obliteration of processus vaginalis. So these are all complications. So now this image here summarizes how you will write a note on cryptorchidism. Please pause the video here and write down these points. Meanwhile, I'll move on to if the testis is not along the path of descent, then where shall I find it? So for this, again quickly revise the various tails of Lockwood, various attachments of Gubernaculum. You remember normally at the bottom of scrotum, sometimes in perineum, base of penis, saphenous opening, anterior superior iliac spine, and so on. So when the testes come at the superficial inguinal ring, they can go to the anterior abdominal wall below the skin. They can go to the under the skin of penis. They can go into the perineum. They can go into the femoral canal or into the anterior aspect of the thigh. So you have to look for testes in all these places. These are ectopic testes. Now suppose this is not the problem, then what else can be a problem in male reproductive system? Anomalies related to processus vaginalis. I have made a separate video related to this, one related to inguinal hernia, one related to hydrocele. But however, let's quickly have a recap of that. So here you are seeing the testis is descending down. Anteriorly, processus vaginalis is leading the way. When the testes reach the bottom of the scrotum, processus vaginalis at this point is in continuity with the abdominal cavity. But once the testis reaches the bottom of scrotum, the processus vaginalis gets obliterated, leaving behind the cavity of tunica vaginalis. This is something we know. But supposing the processus vaginalis does not get obliterated, then it will be in continuity with the abdominal cavity. Correct? See here. There's a continuation. What will happen is, because of the raised abdominal pressure, abdominal organs, especially the small intestine, want to pass through this little processus tube to result in congenital inguinal hernia. Or the fluid of the abdomen can enter through this processus vaginalis tube, resulting in collection of fluid in the scrotum, causing hydrocele. So when the processus vaginalis remains unobliterated, it can result in congenital hernia, it can result in hydrocele. Okay? So what are the types of inguinal hernia? Congenital inguinal hernia you will see. If it remains completely patent, you have what is called as congenital vaginal hernia. You can see the whole yellow tube, it's completely patent. Sometimes it is obliterated just above the testis but patent above. Okay, so all this is all patent. Just above the testis there is a short obliteration of processus vaginalis. This is the most common condition, congenital funicular hernia. The intestines are entering into it till here. This is called as a congenital funicular hernia. Now in the third type, the processus vaginalis is obliterated right till the superficial inguinal ring but proximally patent. So the hernia can form till the superficial ring but not beyond that. This is called as a bubonocele. I have discussed this in detail in my lecture on indirect inguinal hernia. Please do watch that for further details. This lecture does not allow me to go any further. Parallelly, there is also formation of hydroceles. Again, I'll tell you, I've made a separate lecture on hydroceles which are based on congenital conditions. You can watch that. Let me explain it to you here. Come. So there are two types. There is a primary hydrocele, there is a secondary hydrocele. Primary occurs without any underlying condition, usually congenital. Secondary occur because there is a pathology to it. So we are not discussing that. We are discussing primary hydrocele where there is a cause for it, a congenital cause for it. So here you are looking at a normal condition. The intestines are in the abdominal cavity. Processus vaginalis is obliterated. Here's the testes in the scrotum. Okay, this is a nicely obliterated processus vaginalis. Normal anatomy. Now, the processus is obliterated till the deep ring as it should be, and this is the tunica vaginalis sac, which is the distal remnant of processus vaginalis. Sometimes what happens, take a look. Everything is just the same, but processus vaginalis remains slightly large around the testes. Fluid gets collected there, so much fluid that sometimes the testes cannot be palpated in this patient. This is called as a vaginal hydrocele. So why vaginal? Because it's occurring in the tunica vaginalis. Does it extend up into the spermatic cord? No. Does it communicate with abdominal cavity? No. Does it allow for a rising of the fluid up till the inguinal canal? No. It is limited to the tunica vaginalis sac around the testis. Clear? Right. So that's the vaginal hydrocele. Now let's talk about infantile hydrocele. What has happened? There is obliteration, but the obliteration is only at the deep inguinal. Rest of it is completely unobliterated. So fluid gets collected, and the extent of that hydrocele is to the superficial ring, through the inguinal canal till the deep ring. But at the deep ring, there is a closure. So there is no continuity with the abdominal cavity itself. This is called as an infantile hydrocele. How will you differentiate it from vaginal? Vaginal hydrocele never entered upwards into the spermatic cord or into the inguinal canal. So in this case, this continues right up. So you call it an infantile hydrocele. Now you're seeing an encysted hydrocele. See, above and below processus is obliterated. In between, it has remained patent, allowing for fluid collection and formation of hydrocele. Now use your sense to differentiate each of these from each other. Was vaginal, infantile or encysted hydrocele continuous with abdominal cavity? No. There was some amount of obliteration of processus vaginalis. Now let's talk about a condition where processus never got obliterated. There is a continuity with abdominal cavity. So what happens? See, here's the continuity. So when the patient will stand up, he may say that by the end of the day, the hydrocele has increased in size. When I lie down in the morning, the hydrocele is reduced. So this hydrocele can change its size. Okay, why? Because of continuity with abdominal cavity. And there is another condition where the hernia, the intestines also come through that opening, resulting in a congenital hydrocele with an associated hernia. Can you see the intestines coming in? We also want to see what's going on. Okay, so that is congenital hydrocele with the hernia. These are all the conditions you can find as anomalies in the development of male reproductive system. Remember, hydroceles are therefore classified as communicating and non-communicating. When they are communicating, they will change their size. They will communicate with the abdominal cavity. Non-communicating will be some obliteration of processus vaginalis has happened. Okay, the vaginal, the infantile, the encysted are all non-communicating hydroceles. Finally, there can also be anomalies of the male reproductive system per se, such as seminiferous tubules may not get canalized. The efferent ductules may not communicate with seminiferous tubules. Efferent ductules may not connect with vas deferens. There may not be a development of vas deferens. Okay, all this can happen. Come, take a look. So this is the normal anatomy, and now I'm going to remove the labels and show you what can go wrong. So, non-canalizational seminiferous tubules. Efferent ductules fail to communicate. Efferent ductules do not communicate with vas deferens. No development of vas deferens. You can just keep on carrying these anomalies throughout till the prostate. Okay. So, all these anomalies are very much possible. So, what did we learn today? Okay. So, we learned why the testes, we had already developed the testes in lecture 1. So, we had it in the abdominal cavity. So, we asked ourselves the question, why the descent? From where to where is the extent of descent? Then we talked about basic embryological anatomy, testes, gubernaculum, processus vaginalis, and so on. Then we talked about steps of descent, the role of processes, formation of various coverings of testes, timeline of descent. Then we talked about factors that promote the descent. Various developmental anomalies throughout this, such as cryptorchidism, hernia, hydrocele, and anomalies specifically related to the ductal system in the male reproductive system. So we have with this completed the development of male reproductive system 1 and 2. I request you to, if you have missed out on studying the male reproductive system part 1, I request you to go watch it. That's the only way you're going to have a thorough knowledge of development of male reproductive system. Also do watch the development of external genitalia, which is the next part of this series. Also watch Embryology of Hydrocele and a separate lecture on Cryptorchidism. Okay? I hope you enjoyed this lecture. If you've liked it, do like and subscribe to my channel and pass comments. Let me know whether you're enjoying, and thank you for all of you who have been passing comments. Luckily for me, most of them are pretty good. So many of you ask me, ma'am, how do you remember all this? I remember because I draw. All the diagrams that you see are drawn by me. The more you draw anatomy, the easier it is to recall. Because you're not only using your memory to remember, you're also using the other half of your brain, which is basically based on images. So use both halves of your brain, you will be able to remember more. Okay, try it out. So students, I have put up a lot of MCQs and notes on my website to benefit you. Please access those and use them for your personal study and to understand where you are in this subject. Thank you for watching. I'll see you in my next lecture. Bye.